My name is Kurt Schlemmer. I am a staff physician here in otology, or the Department of ENT. And welcome to another episode of The Doctor is In. I'm joined today by one of my esteemed colleagues, Dr. Sandhya Vatakkepatt. She's working with us as an audiologist with a special interest in balance as well. And so today we're going to have a bit of a chat about our balance clinic and our specialized service that we offer here at Cleveland Clinic, Abu Dhabi. So thank you for joining us. We've kind of divided the discussion up into three parts. We'll essentially start with discussing a little bit around what dizziness is, some of the definitions around some of the words that we often use. We'll then move on to some of the more common diagnoses or conditions that we see here and exactly how we test and make these diagnoses. And in a third part, we'll quickly touch on some of the treatment options that we have, and in particular, the benefit of working in a specialized center with a multidisciplinary environment where we can involve our colleagues from physiotherapy, neurology, and so on. So, hi, Dr. Sandhya, how are you doing?
Hi, Dr. Kurt.
Nice to see you, and thank you for joining us on this podcast and conversation. So I suppose to start off with, when we're talking about balance, the brain is really integrating three main inputs, basically what we can see. Yes. So if I'm leaning to the left, I can see I'm going to the left is input from our inner ear, and as I understand it, that is the vestibular organ. And then, of course, what we can feel. So I can feel my weight shifting, for example.
Yes.
But what did you say? What are some common kind of symptoms or complaints that patients might have if they have a vestibular problem?
Usually patients comes with a complaint of vertigo, which is a sensation of spinning. They feel they're moving or the environment is moving. And other common complaints are dizziness, which is more of a general term, which has not really spinning sensation, but feeling of lightheadedness, feeling of imbalance, feeling of faint, about to faint, these kind of are the main symptoms. And other symptoms they come with are nausea, vomiting, ringing inside the ear, heaviness on the ear, moving to the right or left while walking. Sure,
yeah. So it sounds like there are a lot of terms that are used to describe dizziness for our patients,
yes.
Pressure and lightheadedness.
Yes.
Absolutely, and it can be quite confusing to try and understand maybe what is coming from the ear or not. Yeah. Do you have any advice? What do you kind of use maybe on what the patient's saying to try and see is this maybe related to the inner ear or not? Do you have any advice on that?
Yes, usually we look into the term vertigo. Vertigo is like the patient is they are spinning or the surrounding is spinning. Then it's most likely it falls under our scope of practice. Even imbalance falls under our scope of practice, but we look into their complaints or symptoms, like how long does the sensation last or what triggers it, and is there any associated symptoms. So looking into these factors, we get an idea whether the patient has inner ear problem.
Yeah, absolutely. I agree completely. I often find patients may say that when I get up I feel a bit lightheaded, but that may be related to blood pressure or blood sugar. If it's a postural dizziness, and then if the duration of the dizziness is also very long, if it's days to weeks, that tends to kind of maybe be in keeping with something like migraine. If it's very short, very bad spinning vertigo, maybe then sounds more like an inner ear problem, or perhaps change in position, like looking up or looking down or turning the head, but not necessarily moving the whole body.
Exactly.
I completely agree. But that's great. It's great that we can chat about it and share and discuss with the patient what words they use to describe their symptoms. And as you say, it's not that we only do the inner ear, but we're trying to find those things that we can test for to extract a particular diagnosis. Why is it that patients with vertigo in particular often experience nausea and vomiting?
So when there is a conflict of informations, there's a lot of stress hormone released, which will activate certain reflexes and certain systems in our body called autonomous nervous system. As a result of this, we have nausea and vomiting.
Sure. Yeah, thanks. And it seems to be very distressing for our poor patients, feeling so unwell, feeling unsteady, worrying about falling. In particular, patients that have recurrent episodes of vertigo, like many years patients, for example, affecting their confidence to drive and feeling very unwell. I can understand that. So thanks for helping me understand that it comes from the kind of autonomic nervous system and this mismatch of information for the brain.
Yes.
I suppose in its simplest form, it's like feeling car sick or seasickness. It's a similar kind of problem where you're sitting on a boat, you feel like you're sitting still, but your inner ear picks up the motion all the time, and your eyes, if you're not looking outside, doesn't pick up the motion either, and so you suddenly start to feel unwell. But of course, it's not nice to have recurrent episodes of the sickness and so on, and that's why we're here to help. So can this happen in children as well, or is it only in adults?
Definitely, it can happen in children as well, but these are less common compared to adult, and kids can have a various of issues, not limited to certain inner ear, but various of issues, and most of the time they were not able to express the symptoms. So it's usually the parents who notice it and come and tell us.
Yeah, sure. Sure, and it seems to be interesting for me in my experience that children's balance can be affected by things like glue ear.
Yes.
And so often has a correlation with very common symptoms, bit of hearing loss and so on, affecting their balance. And then things like migraine appears to be more common in children, and benign positional vertigo. So certainly it can affect children of any age, and of course adults, particularly as one gets a bit older, they're worried about fall risk. Yeah, that's great. So I suppose in summary, just to start, what we've touched on is that we provide a balance clinic where we try and assess the patient's symptoms of imbalance or dizziness or whichever they describe. We try and isolate those symptoms that may be related to the inner ear, which tends to be vertigo or a sensation of movement, either the patient moving or the environment moving. And then the other specific things on history that we'll check on and elucidate to try and see, is this a vestibular or an inner ear problem, or is it maybe related to the brain or other systemic conditions? Is that about right?
Yes.
Okay, great.
We also employ different diagnostic tests, very specialized tests in Cleveland Clinic, and we do a comprehensive balance assessment, which will also help us to know which part of your ear is affected. Is it coming from your ears or from your brain or something else? Because sometimes patients with, as you mentioned earlier, orthostatic hypotension or hypoglycemia, which is less blood sugar, come to us telling they're dizzy. So first we need to differentiate these symptoms. So we do employ different diagnostic tests, starting from the hearing test, recording the high-speed eye and head movement, stimulating the ears with air or water, hot and cold air and water, and recording the very, very slow eye movements, testing for the fluid pressure of the inner ear. So we do employ a lot of tests to differentiate what kind of problem the patient is facing.
Yeah, that's perfect. So thank you for bringing that up. And that's, our second part is, what are the common things that we see that are proper vestibular conditions and the tests? And of course, it's beyond the scope of this discussion to go into each test in detail. But essentially, we start with this history about the symptoms affecting the patient. We then do a clinical bedside examination. So we'll often ask the patient to stand with their eyes closed, to follow the finger, assess vision. And there is this very close connection between the eyes and the ears and the inner ear, controlling reflexively eye movement. And then moving on to the specialized testing. And thank you, that's exactly what you're able to do for us in the specialized laboratory. But let's choose the most common condition that causes spinning vertigo, which is usually precipitated by movement. So this would be somebody that will maybe roll over in bed and be woken up by sudden spinning vertigo, which is intense, often associated with nausea, sometimes vomiting, but lasts seconds at a time, is BPPV, or benign paroxysmal positional vertigo. So how would we test that in our lab to be able to make the diagnosis?
Usually when the patient comes and tells us, I woke up morning with the spinning sensation, and I stayed in the bed for a few seconds and it settled down. So we get an idea from the case history. Usually it's provoked by a particular head movement or turning to one side. It lasts for a few seconds, then it settles down, and it could occur many times a day. Then we do employ different maneuvers. We move the patient's head in different directions to find out if it is a BPPV, which is benign paroxysmal positional vertigo. So in BPPV, what happens is there are some loose crystals from your inner ear which rolls onto one of the balance canal. So every time we stimulate these particular canals, the patient gets the symptoms back. So we put the patient on a stimulating position and we look for the symptoms. We look when does the dizziness starts, how long does it last, and the time or the fatigability. So we knew it by recording the eye movements or simply by looking at the eyes, and that gives us an idea which ear is affected or which particular canal is affected, and we employ different repositioning maneuvers or exercises to treat that.
Yeah, that's exciting. So it's exactly right, is that if we make this diagnosis. It's one of the conditions that we can treat almost immediately with these repositioning maneuvers, getting the crystals back into place where they should be, and often brings quite rapid relief to our patients, even though it's quite severe. Well, that's great. So something else, for example, is Meniere's disease. Many people speak about or will be told they have Meniere's disease, but it's actually quite a specific condition of fluctuating inner ear fluid pressure, and is usually characterized by three things. It's a blocked feeling in the ear, ringing in the ear, and even hearing loss during an attack of very bad vertigo that usually lasts minutes to hours. Is that correct? Yeah. And then, what in the lab do we use to help us investigate this a bit further?
So, Meniere's disease could affect your cochlea or your balance organ. So first we need to differentiate which particular organ is affected. So we always start with a hearing test. Then we again look into the symptoms of the patient, and there is a particular test called electrocochleography, which measures the fluid pressure. So if the fluid pressure is elevated, or if it's above the normatives, then we consider the patient have Meniere's disease or endolymphatic hydrops.
Yeah, great. And then lastly, one other one that I'm just thinking on the top of my head is that sometimes patients that come in and they're severely dizzy and vertiginous, there's always a concern, is there maybe a stroke? And we've got some testing to help us decide, look, this does appear to be rather one-sided weakness from an inner ear perspective, and there's a sudden imbalance, and so that's why the patient's feeling unwell, something like vestibular neuritis, for example, and that can help us to differentiate straight away whether this is something we need to worry about from a stroke perspective, or is it just a viral infection of the inner ear and the balance nerve? Can you maybe just quickly tell us about video head impulse testing or other tests that we use to see is it a one-sided weakness or not?
Yes, so there is a particular series of tests, we call it HINS, which will help us to differentiate if the patient is having a stroke or inner ear disease. Moreover, the symptoms like slurring of speech, so these things, or a drooping of the face, or all these are not seen in an inner ear problem. And we do this, there's a test called video head impulse, where we rotate patient's head at a high speed. At the same time, we measure the eyes, and we compare the speed of the eyes to the speed of the head. So if there is a lag between the speed of the eyes and the head, then we consider it's an inner ear problem. And we do a few other tests. We close one eye and look at the other eye if there is a drift on the eye. And we look for nystagmus, which is the to and fro movement of eyes. And so these things will let us know if the patient is suffering from stroke or the patient is having an inner ear disease. So it's a very quick test. It won't take long. Maybe we'll be able to reach to a diagnosis within like 10 to 15 minutes.
Yeah, that's great. And then, lastly, I always worry about patients that are maybe a little bit older and are perhaps at increased fall risk. Yeah. Now, someone may have had a knee operation, for example, or it may just be that they're a little elderly or have other conditions that affect their overall balance. And, we want to try and determine, is this patient at a fall risk? Do they need to use a walking stick? And also then perhaps tailor treatment around that. Can you maybe tell me a little bit more about the posturography?
Yes, actually posturography is a test where we assess patients' ability to integrate three different systems that contribute to the balance. As we mentioned earlier, the eyes, the ears, the proprioceptive system, which is our muscles and joints, these three work together to maintain a balance. So the specialized test called sensory organization test, where we assess all these three systems separately and how well they work together. So the patient is made to go through different conditions like standing steady on a platform or standing with the eyes closed. Then we move the visual surroundings, we move the platform they are standing. So we kind of challenge each of these organs and we measure how well the patient cope up in this situation. So we measure their sway, which is the movement. At the same time, we measure the center of gravity. If the patient is drifting their gravity, we check if the patient is using their ankle or if the patient is using their hips to maintain the balance. So while doing this test, we can precisely say if the patient has difficulty maintaining the balance or if they have fall risk. And we can also advise the patient to like the fall prevention strategies, like if the patient has a difficulty with the proprioceptive system, like their muscles and joints, or if they are over dependent on their muscles and joints, we usually tell them that they have to avoid wearing heels, or always they have to look down at the floor when there is a change of the walking surface, like sand, pebble, or an uneven pavement. All these could lead to a fall. Or if they are over dependent on their visual system, we tell them, like, you're walking, you shouldn't be looking at your phone, or when you're in a car, you shouldn't be reading. You have to look around, give as much as visual input to your brain.
Yeah, sure, thank you. And I think it brings us, onto the third kind of thing, is working very closely with our colleagues, like in
Yes.
physical therapy, for example, for specialized vestibular rehabilitation. And it's so nice to be able to work with a team of people that have these expertise, that can help patients recover after these inner ear infections we've spoken about, or after many years disease attacks and they're feeling a little less confident about their balance, or even, as you've now correctly mentioned, all of these strategies to mitigate fall risk. So unfortunately, falling and fracturing a hip in one's older age can actually be, potentially lethal, and so it's really important that we focus on that. So that's great. And in terms of other treatment strategies, of course, there's sometimes these positional maneuvers, working with physiotherapists, and then also working with our neurology colleagues. If it does turn out that there's a concern for migraine, for example, and migraine-associated vertigo, or other neurodegenerative conditions. And of course, then sometimes we'll be using medication. I think many people have heard of beta-histine, but there are many other specific medicines that we can sometimes use. In particular, some cortisone for many years disease. We even inject cortisone into the middle ear, for example. And then quite rarely, but sometimes indicated to even perform surgery. So if patients are diagnosed with things like a superior canal dehiscence, for example, we can operate and assist that. There's even surgical procedures for many years disease and others, but thankfully quite rare, but certainly is something that we can offer, working together with our neurosurgical colleagues and even with an ENT as well. So there are lots of treatment options available. Would you agree?
Exactly. We are actually quite blessed to be in a multidisciplinary team where we have ENTs, neurologists, otologists, audiologists, physiotherapists. We all work hand in hand together to address the issues patients are facing.
Yes, that's right. I mean, even something as esoteric as autoimmune inner ear disease, which also gives you fluctuating balance and hearing difficulties. Again, we've got a close relationship with our immunologists and so on that can assist us. And so that's great. Yeah, so if it's okay, I think I'll kind of summarize a little bit, is that we're very happy to be working together and collaboratively between ENT physicians and audiologists within our department. We are very happy to be looking at any signs and symptoms of dizziness or imbalance or vertigo, kind of extrapolating which of these may be related to the inner ear. We're happy to then offer a whole wide range of specialized diagnostic tests and procedures within the department, and we have nice open communication about those results and trying to get to a final diagnosis. And then really happy to be able to work in this collaborative environment in a multidisciplinary environment to provide treatment options for our patient, whether it be visual vertigo and any other of the conditions that we've mentioned. Is that right?
Yes.
Great. Is there anything else that you wanted to mention or to chat about? I mean, it would be wonderful to have these discussions and an opportunity also where patients could ask questions and we can be guided by that. But I think it's a nice overview just to say that we're very happy to help.
If we get any questions from patients, maybe we can meet again to address those questions.
Yes, of course, yeah. We want to allay fears, allay concerns, and encourage our colleagues to collaborate with us so that we can work together in helping these patients in what is very scary symptoms for them and can really be life-saving if we're mitigating fall risk and so on.
Exactly.
Thank you very much for your time.
Thank you, Dr.
Thanks,
Kurt.
Dr. Sandhya.
Thank you.